So my name is Dr. Lisa Lawless and I'm a GP, and for the last 3 years I've worked with the College Health Service in Trinity College, but before that I worked in the community. So I'll just put this little slide up just as a summary of where I've been. So like lots of GPs in Ireland, I would have worked in hospitals for years, and the one up in the left corner there would be Beaumont Emergency Department, which is one I remember well, and I worked here and spent about 4 years in hospital medicine. I've worked in lots of different types of practices, and the reason I tell you this is, it's, you know, when I come on to working with different types of patients, I think it's important to work with people from different backgrounds. So I've worked in very nice, this is suburban practice. I've worked in Wicklow and worked with CareDoc that cover cover Carlow, Wicklow and Waterford. I've worked, done a little bit of work on the mobile health clinic, which is looking after the homeless people in Dublin, and providing general practice services to those people. Traditionally as a GP we're known to look after people from the cradle to the grave, so as well as looking after people from every kind of background, we look after people from lots of different ages. So what I hope to cover tonight, I was going to talk a little bit about preparing for your consultation, questions that I may ask or your GP may ask, why they ask these questions, what I can do for you, the options for treatments, options for referral, and options to help yourself as well. So, I mean, as a GP, I see probably more depression and anxiety would be top of the list of kind of the mental health complaints that people come with, and then we see some more enduring mental illness like bipolar and schizophrenia, addiction problems, eating disorders as well. But I'll probably stick to the depression and anxiety, as that's probably the majority of the work that I would see. So just starting with some definitions then of health. So this would be the WHO definition of health, and it's fairly aspirational. It defines health as a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. So as I said, it's very aspirational in that there's not many people would describe themselves when they're healthy as being in a state of complete physical, mental and social well-being, myself included. But the important thing is that it's not just physical health, it's mental health, social well-being, and not just the absence of illness or disease. And if we look at the mental health, because that's what we're here for this evening, they define mental health as a state of well-being in which an individual can realise their own potential in life, can cope with the normal stresses, can work productively, and is able to make a contribution to their community. So for me, the important part in that really is coping with the normal stresses of life, because we can't get rid of any of those stresses of life. So it's learning how to deal with them, and feeling well and healthy in yourself. Health is different for everybody, and similarly mental health is. So we will all have different levels that we want to function at, but it's just that you're happy at that level that you're functioning at. So the basics, it's so important to mind your mental health. Your mental health and your physical health are so intrinsically dependent on each other. Without physical health, we need to keep physically healthy to keep mentally well, and similarly, if we're not well mentally, it affects our physical health. And the more recent research will be backing all that up on a chemical level now, even that they just don't exist as two entities. One is very much dependent on the other, and it's really important to take early action, not to wait until things have got worse. So you can build resilience, develop good coping strategies, and when needed, can reach out for help and advice, and don't wait, as I said, for things to become too difficult. I always say never fear criticism, judgment, or not being taken seriously, because that's one thing people will say, you know, I didn't want to go to the doctor because I thought the doctor would say, you know, oh, you know, there's nothing wrong with me, or why are you here, or like, let us make that decision, you know. And you know, if somebody is down or they've low self-esteem, even more so, they're more likely to go, you know, feel like they're going to be judged, because that's just the nature of depression. So it's stepping past that. So it's, you know, just pushing yourself that little bit. Come and talk to us. I love when people come talk to me and I can say, you know, actually, I think you're fine. You know, you've had a bereavement, or, you know, you've lost your job, or there's just loads of stresses at home, and it's actually very appropriate for you to be a bit down and a bit tired at the moment. But, you know, if it's bothering you, come along, and that's what I'll talk a little bit more about now. So just briefly then to go through the symptoms of depression, and I'm sure you've all seen these lots of times before. When people are depressed, they have both physical and mental symptoms. So feeling sad or hopeless, worthlessness, emptiness. Often people will come in to me like that and just say, I'm just flat, I'm just feeling down, you know, I can't get enjoyment out of anything. You know, with that comes just tolerability goes down, or your threshold for just being annoyed with people or things annoying you sometimes. You can have reduced energy, fatigue, loss of interest in daily activities, and then biological symptoms. And by biological symptoms, we mean those symptoms of like affecting your appetite. Maybe your sleep isn't great, that type of thing. Sometimes people will find that they drink more alcohol, almost self-medicating, because then they feel a little bit better when they have a drink. But then the following day, and this is what I tell my patients, they just pay for it, you know, tenfold, because they've almost buffered, you know, those receptors in your brain that were making you feel anxious and making you feel low. And then the following day, when that buffer comes off, you've got these raw endings. So you're more anxious and more tense and can be very weepy. So we'd always encourage people not to kind of self-medicate and not to be drinking alcohol when they have these kind of issues. And then obviously going to the more severe or acute phases, you know, and especially in the young people that I see quite a lot in Trinity, will have a history of self-harming and will have thoughts of self-harming and may have thoughts of suicide when they come to me. And that's something that I try and get out of the way very early in the consultation, because then I know, right, I can sit back and relax and chat to this person, or is this person acutely unwell that I really need to do something to take care of them today. And just symptoms of anxiety. So, I mean, we all know what anxiety feels like, because anxiety is a normal emotion too. It's a normal stress response. But it's when you have kind of pervasive, this knot in your stomach, this feeling of feeling anxious, and it's kind of an inappropriate anxiousness. So you kind of know, I shouldn't be feeling like this all the time. It becomes called a clinical anxiety, because our bodies don't know the difference between us feeling anxious in our head and us being chased by a big brown bear going through the forest. It just perceives, the part of your brain that perceives this threat doesn't know what the threat is. It doesn't know if you've made the threat up in your head or it's a real physical threat. So its response to it is always the same. And it's a physical response to get you out of danger. So it shuts down all those non-essential things, because you're not going to be worried about eating when you're being chased through the forest by this big bear. And you're just going to want to get out of there. So you're not even going to think clearly. So your heart will race, you're breathing rapidly because it wants to get lots of oxygen so you can run as fast as you can. Feeling of panic, sweating, worrying. And then, if you're suffering with anxiety long term, or even over a couple of days or short weeks, you can start getting chronic symptoms of fatigue and headaches. You're not sleeping properly, your stomach doesn't feel right. So they're the kind of symptoms. So why do I say come to your GP as opposed to anybody else? I actually don't mind who you go to. I just prefer people go and talk to somebody. And really, that's my take-home message: is if things just don't feel right, talk to somebody. But then, why not your GP? Your GP is accessible. They're in the community, and I suppose we're trained professionals, so we have the training to go, well, yeah, I think this is okay, or yeah, I think it might be a physical problem, or yeah, maybe there is a mental health issue starting here and we really have to keep an eye on it. Maybe we need to refer you, or maybe we need to see you and offer you some treatment. So I think that's what I have mostly there. So GP, trained professional, confidential advice. Whatever you tell your GP once you're over 18 years of age, stays within those four walls. The only time we'd ever betray that confidence is if there was an imminent threat, either to yourself or to somebody else. But it's confidential. We're impartial. We're not your family, and sometimes that can be a good thing, that we're going to give you our objective view on how we see things, looking down on the situation, because often people involved in the situation, it's difficult to be impartial. And then we can facilitate you if you do need to be referred then on to specialist services, or start medication, or refer you for counselling, whatever you need to. Again, Irish GPs, they've all been through a minimum of a 4-year training scheme, and that's, and it takes at least 5 years after college to get done. So they'll have the experience. They've worked in hospitals. They've dealt with lots of patients. They'll have done one psychiatry job. So they'll they'll have the experience to know what to do, and they'll know what your life is like, and that's really important too. And that's when I was showing you the first slide. The difference between working in a very nice, affluent, suburban area, the stresses and strains on the people that come into my surgery there would have been very different, obviously, to the stress and strains and demands that somebody who was homeless that I was seeing in a hostel were having, or working in a much more deprived area, which I've also worked in. And I have to be always cognizant of that when I'm dealing with my patients. What's realistic for the patient? Number one, what's realistic, because that defines how they define what healthy is and how they define what their mental health is. That depends on what your life is like and what your expectations are like. And then if I want them to make changes in their life, I need to know what changes are possible. If I have a single mother at home with 5 children and I'm saying, well, maybe you need to take a break and go on a holiday, or what would be, I'm not going to tell her to do that if she's not going to be able to do that, Or similarly, if somebody, hates their job, but, they need that job, they have to pay their mortgage or whatever, then leaving that job might not be an option. So it's just important to know about people's life circumstances. Some people have circumstances they can change, and some people have some that they can't. And it just helps them make a plan for the best way of treating that patient. So when to come and see your patient, or come your GP? Again, anytime, things don't feel right. But by definition, a clinical depression is, when you've had these symptoms of sadness or hopelessness or feeling low, kind of with or without these extra symptoms of appetite and sleep changes for 2 weeks or more, and when they're beginning to interfere with your everyday life. So you're just not able to do your normal activities, or you just don't feel like doing them. Again, if you were concerned yourself that your feeling or your behaviour in some way might be abnormal, or it just doesn't feel right for you. If you're concerned your behaviour is affecting your family or relationships or your work. So again, maybe you're tired, you're down, and you just feel your threshold is dropped and you're getting really narky with people, and you're going, this isn't like me, and I really think, I don't like being like this, and I just want to talk to somebody and see, is this a temporary thing? Am I going to feel better? And maybe you want to come and talk to the GP about somebody else in your family who you're concerned about. And I'm always so happy to see people come to do this, and it's not a case that somebody's going to come to me and say, oh, I'm worried about my son, or I'm worried about my brother, and I'm going to pick up the phone and go, listen, your mum was in here today, or your sister was in here today. We'd never do that. I obviously couldn't, because that consultation is confidential as well. But there's always ways around these things, Again, only if, somebody was in imminent risk would we have to look at breaching that confidentiality. So come to me or come to any GP if something doesn't feel right, and the biological symptoms, again, of depression, sleep, appetite, concentration, energy levels are lower. Sorry. Okay, so never feel alone coming to see your GP. About 30% of our appointments are related to mental health. So about a third of the patients I see will be a mental health consultation. And most GPs see about 30 patients a day. Some very busy practices might see 40 patients a day. And they're 10-minute or 15-minute consultations. So if we take, 30, that's 10 mental health consultations a day, 5 days a week. So we're seeing plenty of mental health. Statistically, 1 in 4 people will experience some kind of mental health problem in any 1 year. And by 2020, quite shockingly, depression will be the second most common cause of disability worldwide. So there's a lot of it around. So just to back that up, these would be the statistics really. So the Health Research Board here in Ireland did a huge study between 2005 and 2007. And at the time, they found that 12.5%, so 1 in 8 of the adult population were suffering significant psychological stress. So as I said, 1 in 4, has some kind of mental health issue, but they're saying 1 in 8 would have had a significant psychological stress in any 1 year. So that would be about, at the time, 400,000 Irish adults. We're probably about 500,000 now of Irish adults in any 1 year. Then in general, 10% of people had spoken to their GP about a mental health, 1 in 10 in the last year. And of those, they'd go about 4 times in the year. And if you add that up, it's about 1.3 million GP consultations for mental health per year. Not with the same GP, thankfully, so spread amongst us all. But we're a dwindling number, I'm afraid. And people were asked too what would be the preferred sources of support, and they said family, friends, and their GP. And I think that's a combination of they're the people that are nearest, but accessibility is a big thing as well. We can't, maybe people would like to talk to a psychiatrist or go to the hospital, but we have to look at what's available and what's accessible, and what do we have around us. We have our family, our friends, and in the community there's a GP, and then much more in recent years, people are now looking at, what Aware is doing, so a lot more people calling the support line or looking at our online services as well. So I think that could probably fit in there as well. So how to prepare for your visit, just check our time. As I said, make an appointment. That can be the most difficult step, especially if you're feeling low and depressed, because number 1, you don't really feel like doing anything. And then number 2, your self-esteem is a bit low. So you're kind of like, what will they think of me? Or maybe they think I'm stupid or something like that. If you can, I always say, sit down and write your symptoms and write what's bothering you. It makes it clear in your own head why you've decided to come. And then when you do come and see me, it makes it much easier, because sometimes you walk into the room and you don't remember, and I'm asking lots of questions and things like that. So write down how long they've been affecting you for, because that's really important too, because as I said, we need to decide, is this an acute thing, or is it a normal response, or is this something that's been going on a lot longer? If you think back to when your mood changed, and think hard about when your mood changed. So count back and say, well, it was last May. Think of what happened around that time, and was there anything specific that even, tentatively could have triggered your symptoms now, or certainly made them worse. And it's always worth knowing what that is. Make a list of your other illnesses and your other medications. If it's a GP you know all the time, it'll be on the system. But if not, it's so helpful, okay? And if you've had a problem, similarly a mental health problem before, write down what that was. Was there anything caused it? How long did it last? What helped? What made it go away? Or did it just go away by itself? Or and what didn't help is really important too. Okay, so a GP consultation, as I said, they're quick because we've got to see so many patients in the day, and most surgeries will run on 10-minute consultations. We're trying to move forward now to 15, and I certainly work on 15 minutes because it's not an awful lot of time. So they do have a structure, and when you come into the GP, you may feel like they don't have a structure, but they do, because otherwise we'd never find out what's going on and focus on the actual complaint instead of going off in different directions. So sometimes when people come to me, I probably do throw quite a lot of questions at the beginning, but that's so I can get rid of stuff. You know, I can go, well, it's not that, don't have to worry about that, you know, and I can really start to narrow it down. And some people are good at telling me why they're there, and some people aren't. And I always like to ask, well, what made you come today? Why not last week? Why not yesterday? What made you come today? So traditionally, what you came in the door with was called the presenting complaint, and we're moving away from complaint word because it's a negative word, but it's, you know, it's what you've come with that day. And every time my door opens, 30 times a day, I don't know if it's a toe, a knee, a stomach, a throat, a heart, a mental health, you know. So you're jumping from, you know, you're focusing on one system and then you're on to another system. Very quickly, I like to outrule red flags, and that's what I was saying, those quick questions at the beginning. So if somebody comes in with me with chest pain, that's the easiest one to, you know, I want to know this, you know, 50-year-old gentleman walks into me with chest pain. The first thing I want to know is that he's not having a heart attack there and then. Because then I have to jump into a very different mode. I've got to go, okay, I've got to go get this man some aspirin, and, you know, I've got to ring for an ambulance and might put the ECG leads on and off, that type of thing. So you'll go, you know, how long have you had it for? Is it severe? You know, and he might say, oh, I've had it for a couple of months. And then I go, happy days, you know. So we can sit down, we can relax, we can chat. And he might say, you know, I get it every morning, especially I've eaten a curry the night before. And I'll go, great, we're looking at kind of acid reflux or so, you know. So then that's all the heart stuff gone. And you just, you know, you narrow it down. And similarly with mental health, and you've got to do it. You've got to be much more gentle, though, with mental health. I don't want somebody to walk in the door and immediately go, okay, are you suicidal? Or, you know, have you plans on hurting anyone else? Or, you know, or you can't possibly do that when somebody walks in the door. But so you've got to make a visual assessment, really, and see how that person presents themselves and sit them down and very gently go through the history. But at the same time, get to that kind of, you know, do you have a history of self-harm? Do you have a history of suicidality? And then try and work out if that's a serious intent or whether it's something that they get these thoughts coming and going all the time. So when I finally get to the diagnosis, then you focus on the diagnosis, discuss your options. And I'm going to come back to this more in detail now anyway. And together, and I love this word, therapeutic alliance, I like to make a plan with my patient. I don't like to go, this is what I want you to do. And I turn my computer around and I go, so this is what you've said. So this is my note. Are you happy with that summary? And, you know, I might go, well, we've 3 options. Where are you going? I know where I'm going. Where are you going? But there's no point in me making a plan for somebody if it's not what they had in mind when they came in the door, or it's not what they want. So safety netting in place is literally when somebody's walking back out the door, I really want to leave that door open. So I want to say, you know, if you're feeling worse tomorrow, call me, you know. If you're really feeling bad tonight, or say somebody again was potentially feeling suicidal, they know where they can go, they know the out-of-hours services, they know the emergency department. So it's really important to safety net, because you never want to just get that patient out the door and them not to have a system where they feel they can easily come back in again. You make your appointment in a month or 2 months, but you say, listen, anything changes in between, you come back and see me. Okay, so the questions we ask, as I said, I open the door, what can I do for you today? That's kind of, you know, what I always ask. How long have you been feeling this way? Are your concerns affecting your ability to work? You know, engage with people, concentration, just try and pin it down. This is very much for somebody who's come in with a low mood. Can you identify any precipitating factor? So was there anything in the history that triggered it? You know, was there bereavement? Have you lost a job? You know, have you got financial concerns? You know, because then it makes the low mood much more appropriate. And it may not be that this person has a clinical depression. It may be that they do, but it may also be that it's a normal response to what's going on in their life. Have you any thoughts? And this is about the time, I would probably about 3 or 4 minutes in when I'll come to this question. Have you any thoughts of self-harm or suicide? I'll check out what their supports are, who they live with, you know, who's their confidant, who are they happy to talk to. I'll ask a little bit about psychosis and psychotic symptoms, because obviously if it was a first presentation psychosis, that we wouldn't want to miss that. And then what your history's like, both physical history, medication, psychiatric history. And why I ask them, I've kind of answered this already, but you know, I want to know how long it's been going on. That helps me put this into a clinical situation, or you know, just a change in mood. Is it affecting your daily activities? I want to know the severity, and if it's affecting your sleep, if it's affecting your appetite, if it's affecting your relationships and your ability to work, then that makes it a little bit more severe than somebody who's managing to do everything. Now, some people are great. Some people can have significant depression and anxiety or any mental health illness and cover it up quite well. But some people will find that, you know, they can't manage to do that. And then the risk assessment is those questions: self-harm, suicide, previous suicidal attempts, history of self-harm, history of alcohol use, drug use, and supports. Because when people don't have supports, then they're in a higher risk category. So somebody living on their own with no family or no friends, you know, that puts them in a much higher risk group for me to be letting them go back out the door than somebody's going home to a family who knows what's going on, is very supportive of the patient. And similarly, if they have a history of previous self-harm, then they're in a higher risk group. I assess how long it's been going on, and as I said, we make a plan. So what are our options then when somebody comes to me? So 5% of patients who come to me with a mental health issue, so 1 in 20 will need to be referred on, and that leaves the other 19 for us to look after. So 95% of mental health presentations are managed within the GP setting. When I see the patient, we've done the history, so what else will I do? I'll do an examination if I think it's appropriate, because if I think I want to outrule a physical cause for this patient's symptoms. And I may arrange to get some bloods done. Maybe want to know, you know, if they're tired, it may be their mood, but it may be made worse by the fact that they're also anemic, or they've got thyroid disease or something like that. So I would consider myself thorough, and I would like to do an exam, and I would often like to do some bloods as well. Once I have all that back, then make a plan, and the plan could be as simple as observe and review. So as I said, if it's somebody I'm not worried about, and I'm not sure whether this is actually something clinical, I might say, well, why don't I see you in 4 weeks, and send them away and just make some small lifestyle changes and come back. So that's the, you know, observe and review, lifestyle changes, and some self-help, and maybe use some online services as well if I thought that would help. And support agencies. Medication may be appropriate. I try not to use medication the first time I see a patient. If I don't know that patient at all, I much prefer to get a feel for what's going on. And sometimes that's not always possible. And sometimes they've been through, you know, counselling, and they're actually coming to me going, you know, the counsellor said maybe I should have medication. And that can be different. But it's always my preference to talk first, and then maybe see them a second time, and then start on medication. But I'll talk about the medication a bit more. So the 5% I refer then, so they're either an acute referral, so if somebody I really thought was at risk, and maybe they have to go straight to the emergency department. So that would be one group. Maybe somebody who, similarly, first presentation psychosis that was going to need specialist input, I would refer those on. Somebody with a very complex psychiatric history already, and maybe on lots of medication, and you know, I felt was, you know, again needed specialist input and may need to go to the community mental health team. And somebody who needed to access counselling, public counselling, again would have to go through the community mental health team to do that as well. So medications, well, the one, again, because I can't talk about everything tonight, but the ones I would most commonly use for depression and anxiety would be your SSRIs or your SNRIs, so, or SNRIs. So these would be things like your sertraline, your escitalopram, your fluoxetine. They're the most commonly used antidepressants and anti-anxiety medications out there, and they work by increasing the amount of serotonin that your brain produces, because when you're unwell, you use up your serotonin. So it actually, to get well, you need to bring it back up to a normal level like everybody else. So you have that motivation and energy and go on. So they don't give you extra serotonin, but what they do is they stop it being broken down very quickly in your body, in your brain, and that way then it hangs around for longer and the levels come up. I use it for clinical depression and anxiety if it's pervasive and enduring, so it's been going on for a while, and if they have biological symptoms. It's always a joint decision between me and my patient, because sometimes it works and sometimes it doesn't work. So, you know, I'm not going to tell somebody to take the medication, and similarly, if the patient comes in and says, I want this medication, I'm not going to necessarily give it. So it has to be a decision, an evidence-based, a decision based on the information that we have, and, you know, the expectations of the GP and the expectations of the patient. I give a clear explanation about how they work, the side effects and the risks. The most common side effects I see is gastric and upset tummy, and either feeling sleepy or not being able to sleep. But they generally settle, certainly, and I would say stick with it for the first 2 weeks and they settle. And the most serious risk I'll often talk to them about is one with the anxious patients, that they can get more anxious. And if that was, you know, significant, we would have to look at stopping medication, maybe try something else. And patients who have suicidal tendencies or thoughts, that these can become stronger. And again, I would always caution the patients on this to, you know, stop the medication, let me know straight away if something like that is happening. And that's why I like somebody else to know they're going. You know, I like when people tell their family or a friend or somebody. And not everybody does, but it certainly makes me sleep better at night when I know there's somebody out there looking out for somebody. I tell the patients to have a realistic expectations of lag time, and by that I mean nothing's going to happen for 4 weeks or maybe even 6 weeks. You know, they're not going to work overnight, not this type of medication that I'm talking about. There are medications, of course, for anxiety. If you're using benzodiazepines, they will make you feel calm straight away. But this is a long-term fix. This is not a short-term fix. So I explain that to the patient so they understand that. It's a minimum of a 6 months treatment, I will always say. And actually the new evidence is now that it would be like 9 to 12 months after you're well before we start tapering this medication down. But an absolute minimum of 6 months, as long as it's tolerated. And I always start low. I actually start in a half dose for about 2 weeks to minimise those symptoms of the sick tummy and the sleeplessness or the restlessness and that type of thing. So what you can do for yourself. So, you know, this is a lot of research, a lot of medicine is going towards this way of because we're realising how wonderful the body is actually at healing itself, and how there's so many small little chemicals we were only learning about now that either make you feel physically unwell and mentally unwell, but similarly for every one of those it produces one that, you know, makes you feel well. So if we can harness the ability to produce these proteins and cytokines, as they're called, that make us feel well and reduce the amount of the negative ones, it's like our own medicine from inside. So activity levels so important, and it's not easy for everyone to be active, but the evidence is undisputable. The more active we are, the better it is for our physical health and our mental health. And that's not just a psychological thing, it's actually a very physical thing. And the good news is it's not going for a run, you know, for half an hour every night. It's the really small stuff. It's the standing instead of sitting. Huge implications for your health. When we're sitting all the time, our muscles are just dead, they're just switched off. And once we're standing, they start firing these electrical signals, they produce these chemicals which make us feel better, which reduce our insulin tolerance, so reduce our chances of diabetes, reduce our cholesterol, and this all happens within minutes. by 2 hours has made, and I don't mean stand for 2 hours, but I mean, we all know what it's like to sit and lie on the couch for 2 hours. So, you know, the negative effects of lying and sitting for 2 hours. So stand sometimes instead of sitting, you know, walk instead of going in the car. It's that, and what they're calling now active commuting is the big thing now at the moment, where, you know, we don't kind of walk and drive and get in the car, go to the door of where we're going and go in, you know. In your day, fit in these little bits of activity. So, because I see people just glaze over when I say exercise more, but that's not what it's about. It's just about being more active. And even standing instead of sitting can make a huge difference. If you've got a mental health problem, it's really important to probably stop alcohol or minimise it because of the negative effects it has. I'm not an anti-alcohol person. I'm just saying at that time, you know, if you really want to give your best chance at getting better, it's not going to help. It's going to make it more difficult. Your body loves routine. So again, it's hard to make a routine, but write it down. A regular time to get up, a regular time to go to bed, a regular time to eat your meals. It's not possible all the time. Nobody wants to do it all the time. But if you want to give yourself the best chance of recovering and getting well, this is how to do it. Let somebody else know. As I said, I don't care if it's somebody anonymous on a phone line or whether, preferably if it's family or a friend or a GP. Just let somebody know. And as I said, huge supporter now of, you know, support groups, peer support groups and your online support services as well. Okay, this is a little bit of science, I thought I'd better put something new in, and this is fairly new, but it follows on from the activity thing. So it's the role of inflammation in mental health. Lots of research in it in recent years. We knew inflammation was really bad for physical health. We've had that evidence for years. It underpins all your heart disease, your strokes, your diabetes, your cancers. They're all fed by inflammation. And so what is inflammation? You know, if your skin is red and inflamed and swollen, and that's inflammation as we know it, but inflammation happens on a microscopic level all the time in our bodies. It's how our immune system fights things. So you get a virus, a cold, the reason you get aches and pains is inflammation, and that's why something like an anti-inflammatory, something like Nurofen, ibuprofen makes you feel better. It's the inflammation. But there's a downside to this inflammation, and that's the chemicals that it produces, the cytokines. The pro-inflammatory cytokines are just bad for our physical health, and now we're learning that they have really dramatic effects on neuronal or brain tissue as well, so they're bad for our mental health. So, you know, how can we reduce the amount of pro-inflammatory chemicals that we have going around and increase the amount of anti-inflammatory? And it comes back to activity again. I'm afraid that's a big positive. Activity and exercise, especially, again, not acute exercise, kind of, you know, low grade, just keeping active going along, increases the level of anti-inflammatory activity and reduces the pro-inflammatory activity. So you're reducing your risks for your cancers, your heart disease, your diabetes, and you're also reducing your risk for mental health disease as well. And the other one is reducing your intake of really refined foods. High sugar processed foods are pro-inflammatory or not as well. So they encourage the body to produce these pro-inflammatory proteins, and which in turn cause all those negative effects. So if we can eat less refined food as well, that's like a medicine in itself. And omega-3 fatty acid has also been shown to do that. So I think I'm nearly there. Yeah. Okay, so take-home points. Seek help early. Make an appointment and be prepared to talk and never feel judged. Together with your GP, you can make a plan based on your priorities. So I'm always saying your mental health is not the person sitting beside you mental health, and your expectations for your mental health and your expectations at the level you want to function in society is yours. So don't compare yourself. Everyone's pushing these days. Don't compare yourself to other people. It's whatever you're happy with. Some patients will come to me, they'll need medication, some will need therapy, some will need counselling. As I said, some will just need to a bit of reassurance. When making a plan, look at your life and look at the areas that can be changed and can't be changed. And that's so important, because you're just going to set yourself up for a fall if you really want to change bits in your life that can't be changed. And everybody, ones who are adults, have responsibilities and things in our life that we can't change. Being active is magic. I love it. I should do more of it myself. And be kind to yourself is so important. Taking care of ourselves and not being too hard on ourselves. So that's it. I have a little poem. I don't know if there's many poets here, but I'm a big fan of Brendan Kennelly. And I would have had the pleasure of looking after him, because he has apartments in Trinity, but he's moved back to Kerry now. And I was looking for a short one, so I went for this little one. So down. Why does a poem always go down the page, like a shooting star, or a spade cutting into earth, making way for seeds to nestle in the darkness, and slowly begin to become a small white flower, perfect in the light? So, questions?